Hi, I'm Dr. Torres-Yaghi. I'm the director of the Parkinsonism and Dementia Clinic at Georgetown University Hospital and an assistant professor at Georgetown University School of Medicine. Welcome to this case study presentation sponsored by Teva Neuroscience, Inc. I have received compensation from Teva to give this presentation. Today we will explore the diagnostic journey of a patient with Huntington's disease, or HD, with no prior family history. We will also examine the clinical features of chorea associated with HD, recognize its impact on patients and their families, and review current treatment options. Our patient, David, is a man in his mid-60s. He works in construction, maintenance, and repair. He's married with 2 children who are in their early to mid-30s. David has a history of depression, which is managed with a selective serotonin reuptake inhibitor, or SSRI. About 1 to 2 years ago, David started experiencing involuntary movements in his limbs that were affecting his gait and balance. Since they were not impacting his daily activities, he did not pay much attention. However, over the past year, the symptoms continued to progress, resulting in falls and the development of additional movements in his head and neck. David also started showing new emotional and behavioral symptoms. His wife noted that his depression had worsened, and she also noted irritability, social withdrawal, and the development of compulsive behaviors, such as frequently checking locks and whether the stove was turned off. He also began to experience cognitive challenges, including memory loss, problems with planning, and difficulty paying attention. These symptoms not only disrupted David's daily life, but also started affecting his work performance. His cognitive and psychiatric challenges led to impaired thinking and decreased motivation, resulting in fewer completed projects, missed deadlines, and strained relationships with colleagues. At home, he was less interested in pursuing his hobbies, seeing friends, and was spending less time with his children. Due to these changes, David's wife and children encouraged him to visit his primary care physician, who recognized the need for further evaluation and referred him to a neurologist. Clinical examination at his neurologist's office revealed generalized chorea, impaired saccadic eye movements, and an unsteady gait. His Montreal Cognitive Assessment, or MoCA, revealed mild cognitive impairment with a score of 24 out of 30. To address his psychiatric symptoms, David was prescribed an antipsychotic. Based on David's symptoms, his neurologist suspected HD, despite a lack of family history for the condition. David was referred to a Huntington's Disease Society of America Center of Excellence for further evaluation. HD is a hereditary neurodegenerative disorder caused by an expansion of CAG repeats, 36 or more, in the Huntington gene. This genetic mutation leads to the production of a mutant Huntington protein, which is central to the disease's pathophysiology. In the United States, there are approximately 41,000 patients with HD, and approximately 200,000 individuals are at risk of developing HD. HD is characterized by a triad of cognitive, behavioral, and motor symptoms. Cognitive impairments often precede the diagnosis of HD by many years. Emotional and behavioral symptoms may vary among individuals over the course of the disease. Over 90% of patients ultimately develop chorea, which is characterized by continuous, involuntary, random, jerk-like movements that can occur early on and continue throughout the course of the disease. Chorea, irrespective of its severity, can significantly affect a patient's everyday activities and functioning. Those with chorea might struggle with mobility, often necessitating the use of assistive devices like a cane or walking stick. They may also find it challenging to bathe and dress independently, frequently requiring assistance. Often, tasks like preparing and cooking meals can be difficult, and some patients may need help with taking their medications as prescribed. Care partners consider chorea as the most impactful symptom of HD. At the HDSA COE, David's involuntary movements were evaluated by a movement disorders specialist, and his medical and treatment history was thoroughly examined. The Unified Huntington's Disease Rating Scale, or UHDRS, was used to record his total motor score, or TMS, and total maximal chorea, or TMC score. The TMS is a 15-item assessment tool designed to evaluate motor symptoms in individuals with HD, examining chorea, dystonia, Parkinsonism, motor performance, ocular motor function, and balance. The ratings can range from 0 to 124. The TMC score, which is a component of the UHDRS TMS, assesses movements across 7 areas of the body, including the face, mouth, trunk, arms, and legs, on a scale from 0 to 4. The total TMC score ranges from 0 to 28, with lower scores indicating less severe chorea. David's UHDRS TMS score was 25, and his TMC score was 19. David was referred for genetic testing to confirm the diagnosis. For patients with a known family history of HD, genetic testing is a clear and immediate step to confirm the diagnosis once symptoms appear. Similarly, for patients without a family history of HD, genetic testing should be conducted if other potential causes of involuntary movements are ruled out through medical and medication history. If genetic testing results are negative, other tests and imaging investigations should be conducted. Using this approach helps patients and their families by preventing delays in treatment. David's genetic testing revealed 42 CAG repeats in the HTT gene on chromosome 4, confirming the diagnosis of HD. Sometimes patients with HD may lack a family history, especially in those with late-onset disease. In those cases, relatives or family members with HD may not have exhibited symptoms during their lifetime or had mild symptoms that went unrecognized prior to dying of other causes. To address his chorea symptoms, David was prescribed AUSTEDO XR. AUSTEDO XR, a VMAT2 inhibitor, is a one-pill, once-daily treatment option for adults with chorea associated with HD. Careful consideration should be taken when prescribing due to the increased risk of depression and suicidality in patients. The first HD study which supported the FDA approval of the AUSTEDO BID formulation was a randomized double-blind placebo-controlled trial aimed at evaluating the efficacy and safety of AUSTEDO. The treatment period consisted of an 8-week dose titration phase followed by a 4-week maintenance phase. The main measure of efficacy in this trial was the changes in the TMC score from baseline through the maintenance period of AUSTEDO compared with placebo. After 12 weeks, the TMC scores showed an improvement of 4.4 points with AUSTEDO compared with a 1.9 point improvement in the placebo group, reflecting an approximate 40% reduction in chorea severity in the treatment group. 90% of patients experienced improvement in their movements from baseline. 33% achieved a 6-point or greater improvement, compared to 2% of those treated with placebo. The study also assessed the changes in the UHDRS TMS, which showed greater than 2 times reduction in total motor impairment with AUSTEDO versus placebo. Improvements in physical functioning were assessed using the 36-item short form health survey, or SF36, physical functioning score. Patients taking AUSTEDO achieved a greater improvement in SF36 physical functioning scores at 12 weeks versus placebo and reported improvement in their ability to perform daily activities like walking, bathing, dressing, lifting, moderate to vigorous activities, climbing stairs, and bending, kneeling, or stooping. The most common adverse events in the AUSTEDO group were somnolence, dry mouth, diarrhea, and fatigue. Once patients were titrated to their maintenance dose, these adverse events were no longer reported. 2% of participants taking AUSTEDO withdrew from the study due to side effects. Adverse events of special interest, Parkinsonism, akathisia, restlessness, and suicidal ideation were not reported during the titration phase. During the maintenance phase, they were reported in 4% or fewer of patients in both arms. Anxiety was reported in 4% or fewer patients in both arms during the titration and maintenance phases. In the open-label extension study, which was not placebo-controlled, 119 people with HD chorea received AUSTEDO for about 3 years. This study showed that AUSTEDO maintained chorea improvement over the long term. TMC score reduction was maintained for about 3 years, and there were no new safety concerns in this open-label study. AUSTEDO XR offers flexible dosing that effectively and tolerably manages chorea symptoms. This once-daily medication begins with a 12 milligrams per day dose, increasing by 6 milligrams per day each week until an effective and tolerable dose is reached. The maximum dose of AUSTEDO XR is 48 milligrams per day, with the average dose in clinical trials being over 36 milligrams daily. Patients should swallow AUSTEDO XR tablets whole without chewing, crushing, or breaking them. To initiate treatment with AUSTEDO XR, a 4-week titration kit is available. either as a sample provided directly to the patients or through a prescription. David started AUSTEDO XR at 12 milligrams per day, and the dose was increased by 6 milligrams per day weekly to a maintenance dose of 36 milligrams per day. His SSRI was increased to address his depression and OCD symptoms. For his cognitive symptoms, a cholinesterase inhibitor was prescribed. David receives ongoing support from a multidisciplinary team, not only for the motor, cognitive, and emotional and behavioral symptoms of HD, but also to address the functional impact on him and his family. Physical therapy improved his balance and reduced the risk of falls. Occupational therapy helped with both gross and fine motor functioning, and speech therapy helped improve his executive functioning. In addition, his children will receive genetic counseling to learn about the implications of pre-symptomatic testing, and also support to help manage the emotional and psychological challenges that the family might face. Treatment with AUSTEDO XR led to an overall improvement in David's chorea and physical functioning. On the Patient Global Impressions of Change scale, David rated his symptoms as very much improved. His TMS improved from 25 to 18, and his TMC score improved from 19 to 13. David has now returned to work. To summarize, AUSTEDO has demonstrated efficacy in controlling chorea symptoms in patients with HD, as shown in placebo-controlled studies, with improvement maintained for approximately 3 years in an open-label extension study. AUSTEDO has a demonstrated safety profile. Studies have also shown significant improvements in physical functioning, leading to a reduction in disability. AUSTEDO XR is designed with flexibility to provide effective and tolerable symptom control, along with convenient once-daily dosing. Thank you for participating in this case study presentation. I hope it has offered you valuable insights to assist in diagnosing HD and enhancing the care of patients experiencing chorea associated with HD.
AUSTEDO XR and AUSTEDO are indicated in adults for the treatment of chorea associated with Huntington's disease and for the treatment of tardive dyskinesia. AUSTEDO XR and AUSTEDO can increase the risk of depression and suicidal thoughts and behavior, suicidality, in patients with Huntington's disease. Balance the risks of depression and suicidality with the clinical need for treatment of chorea. Closely monitor patients for the emergence or worsening of depression, suicidality, or unusual changes in behavior. Inform patients, their caregivers, and families of the risk of depression and suicidality, and instruct them to report behaviors of concern promptly to the treating physician. Exercise caution when treating patients with a history of depression or prior suicide attempts or ideation. AUSTEDO XR and AUSTEDO are contraindicated in patients who are suicidal and in patients with untreated or inadequately treated depression. AUSTEDO XR and AUSTEDO are contraindicated in patients with Huntington's disease who are suicidal or have untreated or inadequately treated depression. AUSTEDO XR and AUSTEDO are also contraindicated in patients with hepatic impairment, patients taking reserpine, or within 20 days of discontinuing reserpine, patients taking monoamine oxidase inhibitors, MAOIs, or within 14 days of discontinuing MAOI therapy, and patients taking tetrabenazine or valbenazine. Clinical worsening and adverse events in patients with Huntington's disease. AUSTEDO XR and AUSTEDO may cause a worsening in mood, cognition, rigidity, and functional capacity. Prescribers should periodically reevaluate the need for AUSTEDO XR or AUSTEDO in their patients by assessing the effect on chorea and possible adverse effects. AUSTEDO XR and AUSTEDO may prolong the QT interval, but the degree of QT prolongation is not clinically significant when AUSTEDO XR or AUSTEDO is administered within the recommended dosage range. AUSTEDO XR and AUSTEDO should be avoided in patients with congenital long QT syndrome and in patients with a history of cardiac arrhythmias. Neuroleptic malignant syndrome, NMS, a potentially fatal symptom complex reported in association with drugs that reduce dopaminergic transmission, has been observed in patients receiving tetrabenazine. The risk may be increased by concomitant use of dopamine antagonists or antipsychotics. The management of NMS should include immediate discontinuation of AUSTEDO XR and AUSTEDO, intensive symptomatic treatment and medical monitoring, and treatment of any concomitant serious medical problems. AUSTEDO XR and AUSTEDO may increase the risk of akathisia, agitation, and restlessness. The risk of akathisia may be increased by concomitant use of dopamine antagonists or antipsychotics. If a patient develops akathisia, the AUSTEDO XR or AUSTEDO dose should be reduced. Some patients may require discontinuation of therapy. AUSTEDO XR and AUSTEDO may cause Parkinsonism in patients with Huntington's disease or tardive dyskinesia. Parkinsonism has also been observed with other VMAT2 inhibitors. The risk of Parkinsonism may be increased by concomitant use of dopamine antagonists or antipsychotics. If a patient develops Parkinsonism, the AUSTEDO XR or AUSTEDO dose should be reduced. Some patients may require discontinuation of therapy. Sedation is a common dose-limiting adverse reaction of AUSTEDO XR and AUSTEDO. Patients should not perform activities requiring mental alertness, such as operating a motor vehicle or hazardous machinery, until they are on a maintenance dose of AUSTEDO XR or AUSTEDO and know how the drug affects them. Concomitant use of alcohol or other sedating drugs may have additive effects and worsen sedation and somnolence. Tetrabenazine elevates serum prolactin concentrations in humans. If there is a clinical suspicion of symptomatic hyperprolactinemia, appropriate laboratory testing should be done and consideration should be given to discontinuation of AUSTEDO XR and AUSTEDO. Deutetrabenazine or its metabolites bind to melanin-containing tissues and could accumulate in these tissues over time. Prescribers should be aware of the possibility of long-term ophthalmologic effects. The most common adverse reactions for AUSTEDO, greater than 8% and greater than placebo, in a controlled clinical study in patients with Huntington's disease were somnolence, diarrhea, dry mouth, and fatigue. The most common adverse reactions for AUSTEDO, 4% and greater than placebo, in controlled clinical studies in patients with tardive dyskinesia, were nasopharyngitis and insomnia. Adverse reactions with AUSTEDO XR extended-release tablets are expected to be similar to AUSTEDO tablets. Please see full prescribing information, including box warning, at austedohcp.com.